Okay. Good evening, everybody. Welcome to this another session of the Resident Smart Learning Program, which we are having every Tuesday from 7 to 8:30. Today, we have the subject on priapism, which is an important topic which you have to know because there are a lot of issues which come up regarding the management. And we have Dr. Vinod KV who will be talking on this subject. And I hope you will enjoy the session. I would now request Professor Sood to make his opening remarks. Over to you, Dr. Sood.
Thank you, Dr. Keshav. Today, we have another session on men's health, and this is related to sexual medicine also. And the topic is priapism. This is very important topic. And residents, when they are on duty, sometime odd hours also, they will see certain patients where swelling of penile swelling is there, or there is erection, persistent erection, or during the day also, as has been discussed time and again, there can be priapism or as a complication of various thrombogenic problems. Now the problem is that this priapism is to be differentiated from the priapism which is going to be harmful in the long run for the sexual function, and also the possibility of priapism when you are doing some of the procedure which Dr. Vinod is going to cover. And also today we are in the era of COVID, and already because of the this problem of coagulation problems and thrombotic problems, there are 3 cases already reported in the literature, 2 from UK and 1 from US, which they are attributing to COVID. And this all is in addition to the ischemic priapism, which was in addition to maybe leukemia, maybe chronic myeloid leukemia, or it can be because of the sickle cell anemia. So various reasons are there. I remember that there was one case when I was myself MCH student, and that became the part of my thesis also. There was a very rare case where this was a infant, and there was a pyocavernosis, and that caused priapism, which was ultimately reported also. Very few, I think 4 or 5 cases are reported. And therefore, today, when we are talking about men's health and some of the known ED problems of men, which include the priapism also, this should be known to everybody. The residents encounter it at odd hours. How to treat early, how to treat the delayed priapism, and what is to be done when kid is there. A small kid is there, and the BP cuff is to be available, maybe the small size also in the manage for the management, whether it is an emergency or we can wait till the morning and do the conservative measure. These all aspects are there of priapism, and various kind of priapism which Dr. Vinod is going to teach. And this is the virtual classroom. This is the distant learning which is going on, and under ISU and USI. And we have the eminent professor, Dr. Vinod KV, who is very experienced and in the men's health also, as well as in the urological teaching. And the residents are lucky today to have such a great teacher. I hope that this is going to be very, very interactive session, and all the residents are requested to ask as many questions as possible, and also interact whenever they have any doubt or any further question. And with this, I'll now hand it over to Dr. Vinod KV through our secretary, Dr. Keshav. Dr. Keshav, please.
Thank you, Professor Sood. I would now request Arun Chawla to introduce Dr. Vinod KV and the session. Over to you, Dr. Arun.
Thank you, Dr. Keshav. I think Dr. Vinod doesn't need a formal introduction, especially for those who have attended the 2020 Kochi Annual Conference last year. The residents who are new probably may not be knowing him, and for those who don't know closely, I'll just briefly say Dr. Vinod KV is uh, passed his MBBS from Government Medical College Trivandrum and did his MS and MCs from Government Medical Trivandrum, Kerala University in 2004. From 2004 till now, he has been working as a consultant in urology in his own center and is attached to various other hospitals in Trivandrum. And the subject of andrology and men's health has been very close to his heart. He's very passionate about this subspecialty. And he has made a lot of contribution to this field by organizing various workshops, instructional courses in this area at various levels, state levels, the zonal levels, as well as the national levels, the conferences held under the aegis of USI. At present, he is a council member from South of the Urology Society of India. I have closely worked with him as a council member to the Association of Southern Urologists, and what I have found him as a very, very affectionate personality with very pleasing manners, and always ready to help anybody who comes and seek his opinion. With this brief introduction, I will invite Dr. Vinod KV for his talk on Priapism, a subject which is very important for all the residents. The pathophysiology of Priapism, which comes as a short note or a long note, it may be a essay type or it may be short note. The agents used to induce detumescence early, it comes in the form of sort of pharmacology. The shunt may be given, the name may be given, you should be aware of the names which Dr. Vinod will be discussing. All this carries a very, very patient listening from your end for next 1.5 hours, which will be followed by a quiz which you have to answer, the link will open at 8:25. I think Dr. Keshav would have already put the link on the group. Is it done, sir? You're muted, sir.
Yeah, I will send it now.
Yes, yes. With this, over to you, Dr. Vinod.
First of all, I thank Urological Society of India and the Indian School of Urology for the opportunity to be part of this USA Resident Smart Learning Program. I'll be sharing my slides now. Is it visible for all of you?
Absolutely clear. Fine.
Yeah. So also, thanks to Dr. Arun Chawla for his good words about me. Also, I thank all the residents who have joined in the middle of COVID-19 crisis to be part of this program. In the coming 60 to 75 minutes, we will be discussing the basic essential concepts of Priapism. We can discuss the etiology, pathophysiology, and classification of Priapism. Also, we will be addressing the issues in the evaluation and management of such a patient. As Dr. Arun Chawla has mentioned, in your examination, these concepts may be asked in the theory paper and may appear in the viva as a sudden blow. More likely, there will not be a case in the practical examination. So this session will be more helpful for you when you start practicing after your studies. You have to be clear about the evaluation and management of this problem, since you may be all alone in front of a Priapism patient and have to act fast and cannot get help from anybody else. Priapism is an uncommon medical emergency. You may get cases if there are more patients using intracavernosal injections or you work in an endemic
Dr. Vinod, the connection problem is there?
Yeah,
Or what is
connectivity. I think a little unstable connection. He'll come online. Yeah.
Pardon me, he is.
Navneet, can you mute Dr. Vijay Kumar?
Arun, I spoke to Vinod. His laptop gave some problem. He's setting it right. It's opening up now.
Okay.
So, Keshav, you can speak something about Priapism in the meantime.
So, Keshav, I want to say, Keshav,
Yeah,
Sanjay
yeah.
Kulkarni.
Sanjay.
Yeah,
Dr.
Yeah,
Sanjay,
sir.
good evening.
Yeah, good evening. We do duplex color Doppler for erectile dysfunction in lot of pelvic fracture urethral trauma patients, and the test should be done in the morning, not in the afternoon, because in the event I do it at 6 o'clock in the evening. If he goes into Priapism, I have to do detumescence at 10 o'clock at night.
Correct.
So we always want to know this very important point, that if you want to do a duplex color Doppler pre and post papaverine, it has to be done in the morning, so that the patient can be taken to theater if required within 6 hours. So normally we finish surgery by about 5 or 6 o'clock in India. So we want to take the patient to OR at about 4 o'clock. So we should start early, 8, 9 o'clock duplex color Doppler. And we do it. We don't send the patient to a radiologist.
Dr. Sanjay, when you are talking about this investigative procedure, we
Yeah.
get a lot of patients, a lot of accused in the rape cases. When the victim is brought, the accused is brought. And if they are not ready for the self-stimulation and to show their capability of erectile function. And if you give any injection, papaverine, maybe testing for half ml or so, and pre-existing medical conditions we don't know. Is there any medical legal implication of that?
I think he's back. He's back. I think he's back.
Dr. Rajiv, we will discuss later.
Yeah.
Thank you.
Am I audible now?
Yeah, Vinod, you're audible.
Yeah. I'm extremely sorry. My laptop got shut down. I'm sorry. So we were discussing about the characteristics of priapism. Priapism is an uncommon medical emergency. So you may not get very frequent cases of priapism, but you have to, once you get it, you have to manage it. The main thing about priapism is the early detection and the timely intervention. Rest of the things are all fine, but you have to find it early and intervene it at the appropriate time. But don't think that all priapisms are emergencies, but you have to be there beside the patient to decide whether this priapism is an emergency or not. When you try to understand the disease process and its management, the main challenge you face will be the limitation of medical literature available. Since this is an uncommon disease, we can pick out only case reports and small series which hold a very low strength in terms of evidence. Follow-up is also very limited, which further compromises the quality of the data we have. The whole set of data we gather span a long period of years, where you can see the scientific concepts have taken a paradigm shift. So the data becomes non-comparable. In general, we have to work with a compromised quality of data. AUA, EAU, and International Society of Sexual Medicine all have brought out their guidelines, which remain static without much revisions because there are not many data coming forward in this field. With this prelude of disclaimers, we will start to understand the disease priapism. Priapism is defined as partial or complete erection lasting greater than 4 hours beyond sexual stimulation and orgasm or unrelated to this. The erection need not be the rigid one. Even the persistence of tumescence has to be considered significant. This can come after a sexual stimulation or without any. This may start in sleep even without a sex dream. And it is calculated after the termination of sexual stimulation and orgasm. So you can have sex for 4 hours or more with a proudly erect penis, and nobody will label you as having a priapism. But the question is, what you will call a penis which remains erect even after your orgasm for more than a few minutes to the cutoff period of 4 hours. They are termed prolonged erection, not priapism. Most of them will slowly settle. They are not pathologically very significant to us unless it appears very often. The hypoxia acidosis cascade will slowly develop after 4 hours. That is the logic of the magic number 4. But nobody prevents you from managing a prolonged erection, but not in the name of priapism. Now let us look at how this happens. In normal erection, during sexual stimulation, there is increase in arterial inflow into the corpora cavernosa, followed by relaxation of cavernous smooth muscles and occlusion of the venous channels. Corpora becomes turgid and arterial flow then slows down. This finally results in the erection. After ejaculation, the venous channels open and the cavernous smooth muscles contract to produce a drainage of blood and detumescence. What happens in the veno-occlusive priapism? The process of erection happens normally, but the detumescence phase fails. The venous channels remain occluded and the cavernous smooth muscles stay relaxed. In this setting, the arterial flow is very feeble due to the increased intracavernosal pressure and remains like that. Hence, it is called low flow or ischemic priapism. In the second type, the arterial inflow is increased due to trauma or fistula. The venous mechanisms remain intact. Hence, it is called the arterial or high flow or non-ischemic priapism. There is still another category which is not exactly fitting into both the low flow or the high flow. Stuttering priapism. Here, the basic pathologic mechanism is the same as in ischemic priapism. It is something which coming just like an ischemic priapism and resolves by itself often and have repeated episodes, unlike a classic ischemic priapism. So the repeating episodes is the classic feature in stuttering priapism. It may not go into a priapism at all. It may remain just like a prolonged erection, but it is maybe called as a prodrome of an ischemic priapism. Now we can look at what is happening in the neurotransmitter level in ischemic priapism. Our understanding of the pathogenesis of priapism has made paradigm shifts in the past few decades, especially with the understanding of the nitric oxide signaling mechanisms. The erection flaccidity cycle is mediated through nitric oxide, cyclic GMP, PDE5, or ROA and ROC molecules. What happens in priapism is a dysregulation of the neurotransmitters. The pathologic events happening after the onset of ischemic priapism is very interesting. The cascade of events is similar to what is happening in compartment syndrome in muscles or inside the abdomen. Once there is venous occlusion, the intracavernosal pressure rises and the arterial flow dampens. This creates hypoxia and hypercarbia, which in turn leads to acidosis. These metabolic changes trigger histologic abnormalities inside the corpora. Within 12 hours, interstitial edema and thickening sets in. Within 24 hours, the sinusoidal epithelium gets damaged, exposing the basement membrane. As we all know, the stagnant blood in our body will not clot unless it is exposed to a damaged or a degenerated tissue. So we have a static blood inside the cavernosa, and you have damaged sinusoidal epithelium and the opened up basement membrane. This sets in the process of thrombosis. Thrombus formation inside corpora is responsible for the persistence of the priapism. This signifies the importance of interventions before 24 hours. By 48 hours, a sizable amount of smooth muscle necrose causing collapse of the sinusoids, the basic architecture of the corpora. The beta transforming growth factor will stimulate fibroblasts like cell formation and start the onset of corporal fibrosis. This is in fact the death of the corpora when it cannot perform what it is meant for. The progressive damage of corpora with time points to the need for early intervention in such patients. The histological comparison is shown in this slide to give you a visual idea of what is happening microscopically. The picture on the left, you can see it is from the normal, and the other one, the priapism. The brown colored things are the smooth muscles, which is very rich in the normal one, and it is otherwise in the priapism biopsy specimen. If you look at on this slide, you can see the elastin fibers, which is the violet shaped ones, are very little in the normal cavernosal biopsy, but it is in plenty in a priapism patient. So the basic thing is the loss of smooth muscles and increase in fibrosis, which is the ultimate result of a priapism, and that is what we want to prevent. Now we will see how does the pathogenic changes which we have mentioned is manifesting in the patient. The patient will have a prolonged, painful, rigid erection. Pain and rigidity are the hallmark signs in ischemic priapism. The corporal blood aspiration will show hypoxic, hypercarbic, acidotic blood, as will be evidenced in the arterial blood gas analysis. We will be discussing it after a while, the details of this. You can document the reduced arterial flow and clots in the corpora if you do a color Doppler ultrasound. If you are not able to identify and relieve priapism in 36 to 72 hours, the chance of erectile dysfunction is high. I am stressing this point because this is the most practically important point. The causative factors for ischemic priapism are varied, and you have so many, but the most important, most of them will be idiopathic. Also, we have to concentrate on the possibility of a hematological dyscrasia associated with it, like sickle cell disease and thalassemias. The other causes may be a rare occurrence, as Dr. Sood sir has previously mentioned. There are some rare conditions where we can get it, and in neoplastic cases, if you will get a few number of cases, if you are attached to a cancer center, and in some patients with even spinal anesthesia, we can get that. So we will be having a lot of causes to be mentioned, and why priapism happens in it is itself is a matter for long discussion. Now coming to the drugs causing priapism, the most common culprit will be the intracavernosal injections we give to the patient either as a diagnostic or a therapeutic for therapeutic reasons. And also we have so many drugs reported to be as a causative factor for priapism. Now coming to the next category of priapism, which is a non-ischemic or high flow or arterial priapism. What is a pathophysiology? A perineal injury, it could be a blunt injury or a sharp injury. It need not be a perineal injury itself. Any other injury also can precipitate a priapism. It can be an immediate rupture or a delayed rupture of arterioles communicating with the sinusoids, producing an arterio-sinusoidal or arteriolacunar fistula. So this sets in just like when you poke a needle in the kidney, you have an AV fistula, you have something like a arterio-sinusoidal fistula, which causes an increased arterial flow. But at the same time, this patient has a normal venous flow. This is how the high flow priapism sets in. The non-ischemic priapism, the manifestation will be a painless, non-rigid tumescence or erection. The penis will not be that rigid as you see in an ischemic priapism, and it is painless. In such patients, if they are having a sexual stimulus, they may have a rigid erection. Later again, it becomes a tumescence and it remains like that. And pain is very rare except at the site of injury, whether it be perineal or in the penile region. It can remain for years with no effect on erection. The patient will have normal erection. So this is not an emergency. The lacunar walls are less rigid and are prone to thrombus. Hence, the chance of spontaneous resolution is very high, around 62%. And it usually follows a straddle injury and may appear days to weeks after the injury. And that is why it is very important to have a physical examination to locate this non-ischemic priapism and differentiate it clearly from an ischemic priapism, which is an emergency. Now coming to the third category, stuttering priapism. It is recurrent, unwanted, painful erections, varying in frequency and duration. It may be an interval of days to weeks. This may be a child who is having erections very often. And some of these episodes may progress to ischemic priapism. It may be considered as a prodrome or something like that. Or in some patients whom you have treated ischemic priapism may have a stuttering priapism for some period of time. But it is more commonly described along with sickle cell disease. They are more prone for a stuttering priapism. Now, how will you clinically evaluate a patient with the priapism? I am not going to the systematic examination. Just the key points in history. What are the key points in history you will see? The most important point you have to see is the duration of erection. When it started and what are the treatments taken, these has to be clearly interviewed and noted in the case sheet because it is of very high medical legal importance. Second thing is the presence of pain, which will differentiate between a ischemic and the non-ischemic variety. And the treatment of the present episodes, whether somebody has poked a needle inside, any drugs taken. So these are the things which are very important when you are planning the management and making a clinical evaluation. Because if you have a patient with ischemic priapism and somebody has put a needle or done some aspiration, it may remain a little bit less rigid, and you may think that it is a high for priapism. And in some patients, when they have aspirated and the patient with the penis may be normal, it may be having flow, but you may think that it is again an ischemic priapism. So the treatment of the present episode is very important. How to differentiate each of the situations will be coming later. The history of treatment of erectile dysfunction with some injections, and the presence of that itself gives a clue to the presence of erectile dysfunction in this patient pre-existing. And trauma to the perineum or pelvis, unless specifically enquered, that they may not come out with that history, and of course the medical and medication history. The one important thing is the duration of erection has to be confirmed from the patient and documented. This is very important because some of the patients who may be taking recreational drugs, they may not come out with history, correct history, or they may not be knowing the things. And some patients may hide things. Some may be having psychiatric problems. So all this has to be documented because this can go for a medical legal issue later. Among the drug history, the most important one will be the oral drugs taken, which is for the treatment of the priapism or even for otherwise, intracavernosal injections and some diagnostic techniques done by some other specialists or even a radiologist. Now comes the lab evaluation. What are the things you will do for a lab evaluation? Of course, you need a blood routine examination to check for the anemia, which will be pointing to a sickle cell anemia, or a total count to see whether there is an infection, leukemia. Reti count will be helpful. The coagulation profile will be helpful in even planning your case. And sickle cell preparation and hemoglobin electrophoresis in a patient where you genuinely suspect a sickle cell disease or a thalassemia. The corporal blood aspirate is one of the most important thing which you can do in differentiating priapism if it is needed. In some of the cases, it may not be needed. It is the aspirate is called as crankcase oil appearance. The initial samples will be just like almost black. These black samples has to be sent for the aspirate for the arterial blood gas analysis. Once you aspirate, you should not be sending the later samples which may be normal. So if you want the classical values and for a clear diagnosis, you send the initial samples. Now comes our options of radiological evaluation. A color Doppler ultrasound will clearly tell you what is high flow priapism, whether it is a low flow priapism. But it is not very commonly done in an ischemic priapism unless it is in a doubtful condition. When it is a partially treated one, you may have a doubt that whether there is a normal or not. I'll be coming to the details after 1 or 2 slides. And post intracavernosal injection less than 7 hours, it may have a picture of both high flow and low flow. So in such doubtful conditions, you may need the help of a color Doppler ultrasound. Otherwise, you may not need an ultrasound, which is evident with when you examine the patient. And in some patients, you may be doing an aspiration. You find you attain tumescence, and after some time, you again see there is some rigidity or some tumescence. Whether it is a recurrence or it is just a post ischemic hyperemia. If you want to differentiate, you have to do an ultrasound. I will be coming to the details later. If you're doing an MRI, you will know the arterial or sinusoidal fistula. This may be done mostly in case of a high flow priapism. Presence and extent of tissue thrombus and corporal smooth muscle infarction, and assessment of corporal fibrosis and corporal mets in malignancy. These are the things which can be picked up in an MRI, but you may not be routinely doing an MRI for such a patient. In some of the suspicious cases, or when you have you are planning a surgery, you need an evaluation for a documentation purpose or for a medical legal purpose. You can document all these things so that it will not backfire you later. Now I will come to the differential diagnosis. What are the things which you have to keep in mind when you are seeing a patient? You have to differentiate between a low flow priapism, high flow priapism, post ischemic hyperemia. Post ischemic hyperemia is something which comes when you aspirate or when you clear a priapism, by doing some of your shunt surgeries or by aspiration of corporal blood. Again, there at that time there will be a low pressure in the cavernosa. There will be flow of blood into the corpora, and it will appear like a priapism. At the same time, there will be some tissue edema, which make you very difficult to find out whether I'm dealing with a low flow, high flow, or a recurrence. Clinically, a low flow and high flow can be differentiated. If you have a pain, you have a low flow. If you have a rigidity, it is low flow. If you have no pain, it is high flow. If there is only tumor sense, it is high flow. Then comes the in between things, how to differentiate. In such a case, if you are doing a corporal blood aspirate, if you are taking, aspirating a patient with ischemic priapism, the PO2 will be very low, 30, and the PCO2 will be 60, and pH will be less than 7 So you have an acidotic environment, a hypoxic, hypercarbic. If it is a high flow priapism, the PO2 will be very high, just like an arterial blood, and the PCO2 will be low, and it will not be acidic. It is just like an arterial blood. So, suppose you are dealing with a post-ischemic hyperemia or in a flaccid state, you will be mainly getting a mixed venous blood pattern like PO2 of 40, PCO2 of 50, and pH of 7.35. At the same time, we have to keep in mind that in low flow priapism, the typical pattern appears only 6 to 8 hours of complete venous occlusion. So if you are taking it in the initial hours, you may not get a typical picture as we have mentioned here. So this fact also has to be kept in mind. That is why we are taking the first aspirate and sending it to the lab. So we will be in clear-cut cases, there is no problem in diagnosing, but in some cases you will have some problem in getting into diagnosis when you can use the clinical picture, the corporal blood aspirate ABG analysis picture, as well as the color Doppler ultrasound. In color Doppler ultrasound, if you have a low flow priapism, there will not be any arterial flow or a very little arterial flow. High flow, it shows a high arterial flow. If it is a post-ischemic hyperemia, there will be increased arterial flow. So even though the patient gives a history of priapism, but when you're looking, you are not seeing that it is not that urgent. Your suspicion will be whether it is a high flow or a post-ischemic hyperemia when the previous surgeon has aspirated it. In that case, you can look at all these aspects, the corporal blood aspirate analysis as well as the color Doppler ultrasound, and the history will be helping you in making a differentiating what is what. Now we'll just take a recap of what are the types of priapism we have dealt with. Ischemic is a painful rigid erection and this low arterial flow. Ischemia, hypoxia, hypercarbia, acidosis, hallmark of ischemic priapism, and smooth muscle necrosis and fibrosis are the things we want to avoid, and erectile dysfunction is the final problem in ischemic priapism. And non-ischemic, it is a painless, non-rigid erection with increased arterial flow, no ischemia, no erectile dysfunction. So you can be happy about that. And it's a case which can be kept in abeyance. Stuttering priapism, the main issue will be the recurrent episodes. And it may sometimes progress to ischemic type. And it is associated with, you have to check the possibility of a sickle cell disease. So the treatment principles in nutshell is low flow is an emergency. High flow, observation, embolization if needed. Stuttering is prevention. So what causes the delay in a patient coming to you with an ischemic priapism? Why can't you think that the patient is coming, rushing to you? There are many factors. One is a patient factor, embarrassment. He will uncertainty. He thinks that it will come down and he will wait for hours, and finally he will be losing the golden hours. And some of them may be intoxicated. They have the priapism set in at the time of intoxication, and when they wake up, they see their erect penis, and they don't know when it has happened. Also, in the health system, it may be hospital-related issues will be there. There will be some delay in the ER. You will be A roaming urologist, you may not be available there. You will come late. You will see the patient a little bit late. And some surgeon or some physician may think that we will try oral agents for some time, and some conservative measures are done. All these can cause delay in the treatment, which may prove to be harmful in a ischemic priapism. The main principles of management in ischemic priapism is the etiology, how it happened, what created it is not that important in the initial management. The emergency intervention is aimed at preservation of the erection and prevention of the corporal fibrosis. The main thing you have to keep in mind is there is no role for oral medication in an ischemic priapism once it has set in. You may treat for a prolonged erection. You may treat for a prolonged erection, but not for a set in priapism because you have no time to lose. Aspiration, saline flushing, intracavernosal injections of sympathomimetic agents, and surgical management includes the different types of shunts. And the most important part is the consent, and sometimes even we may have to focus to a very great extent in the consent because it is a highly litigious condition. Just like Dr. Lakshman was sharing his experience, a psychiatrist has treated a patient. He has put in intracavernosal injection. The patient got very stiff erection. He intervened. Then the patient later became important. And the contention of the patient is, when I came here, I came with a very big erection, and this doctor has treated me, and I became important. So everything has to be documented, a detailed consent with the witness, and document everything with the time, which is the most important factor when you explain it after the procedure. The first procedure we do is an aspiration. You can use a 19 gauge or bigger needle. One side is sufficient because of the incomplete midline septum, but there are some studies saying that you can aspirate on both sides, but one side is quite sufficient in most of the situations. You have to choose a 3 o'clock or 9 o'clock position at the penoscrotal junction and apply pressure proximally and aspirate till bright blood. Usually you have to aspirate at about 120 ml, and more than that may not be necessary if it is an early case and you will have a detumescence. Some people will do an aspiration alone, and some will have do an irrigation with the cold saline, just like if you keep a three-way connector, you can do an aspiration, then you can irrigate with cold saline, but there is no proved added benefit. But there are some studies proving that there is some benefit of irrigation with cold saline along with aspiration is giving you a better result. A basic idea is to remove the anoxic, hypercarbic, acidic blood after the corpora, which will create a better environment, prevent the smoothness of necrosis, prevent the sinusoidal damage, and it will finally decompress the corpora, and the patient will be reduced to have a reduction of pain, and the fibrosis process is stalled. The second option is the intracavernosal sympathomimetic agents. There are a lot of sympathomimetic agents mentioned if you go through the literature and in the textbooks, but the most important one will be the phenylephrine. I will be discussing it in a separate slide. Also, you can use epinephrine, but there are a lot of catastrophes happening with epinephrine, norepinephrine, ephedrine, metronidazole, etelephrin. For sure, I think most of you might have seen only phenylephrine. And there is a description of methylene blue. It's a guanylate cyclase inhibitor, 50 to 100 milligram. Keep it, inject for 5 minutes, aspirate, and then apply pressure. A bluish discoloration of the penis comes, and the main problem will be a burning sensation. This is just mentioned. And adrenaline, we are not regularly using adrenaline, but if you are not having phenylephrine, you can try this. 1 ml of adrenaline, 1 in 1 lakh, 2 ml of each for 5 times in 20 minutes. You can be used, which will work as an intracavernosal sympathomimetic agent. In priapism, secondary to intracavernosal injections for a treatment or a diagnostic purpose, injection of sympathomimetic agents without may be done even without aspiration. So usually we initially do an aspiration, remove that hypoxic blood. The logic of removing the hypoxic blood is the sympathomimetic agents, the alpha stimulants, alpha adrenergic stimulants will not act in an acidic environment. So either it should be very early, as in IC ward, we have the patient with us, we know the history, we know everything. You can directly inject because there won't be that much acidosis happening in that situation. That is why it is directly administered. Otherwise, it is always better you aspirate. If you want to flush it, remove that acidotic environment so that your sympathomimetic agents will work. Otherwise, it may not work just because of the change in pH. Phenylephrine is the commonly used one. It has less beta adrenergic action. That is why it is more preferred. It is less active in acidic pH, as I mentioned, and hypoxia. It is effective only up to 24 hours. Less effective after 24 hours due to acidosis. So it has to be used early. And the dosage is 100 to, there are different dosages given in different guidelines. You can choose whichever is comfortable for you. 100 to 500 micrograms per ml solution, 1 ml every 3 to 5 minutes for 1 hour. That is AUA recommendation. 200 micrograms per ml solution, 0.5 to 1 ml every 5 to 10 minutes for 1 hour for a maximum of 1 mg. So in general, the maximum limit is kept as around 1 mg. There are some personal experiences like Tom of you who has shown that, who has mentioned that he will go a little more with phenylephrine because it is a safer drug. But generally, we get phenylephrine in 10 mg ampules, where each ampule will be having 1 ml. So 1 ml will have 10 mg. You can put it in a 100 ml saline, normal saline. So each ml will be 100 micrograms. Or if you don't want to have a 100 ml saline, you take 0.1 ml of the phenylephrine. So it will have 1 mg. Dilute it with 10 ml saline. So again, you have 100 mg. You inject 100 mg or 200 mg every time, every 5 to 10 minutes. And you go up to a maximum of 1 milligram or 10 injections. So that is a general practical way of doing things. The only thing is you have to monitor the heart rate and BP, and some patients may have headache. There are some patients who may be predisposed to arrhythmias, or if they are having a hypertension or hypertensive crisis, they can have a problem. And in children, you can actually reduce the dose, and suppose you have a cardiac patient, you can reduce the dose and you can titrate it. And now I'm just keeping a distractor. It is not part of my discussion. It is just to ease down all the pathogenic things, your aspiration and other things. This is a curious thing happening in mostly in a sickle cell patient. There are a few case reports of megalophallus. Hello? Hello, can you hear me?
Yeah, we can hear you. We can hear you.
This is called the megalophallus. Here you can see a non-tumescent, uniformly enlarged penis with the widest circumference of around 19 centimeters, 19.5 centimeters. But you can see the glands is normal. So there is something happening with the corpora cavernosa. This is a priapism which has happened in sickle cell disease. And after that, what happened is the theory proposed for this situation is there is a loss of elasticity of the tunica albuginea. So there is an increased girth of the corpora cavernosa, and there is a deoxygenated blood inside that corpora cavernosa, but it is functioning normally because there is no other abnormality happening. It is just a dilatation of the corpora cavernosa because of the loss of elasticity of the tunica albuginea, which is providing this megalophallus. Just to give a break for our continuous discussion. Now we will be going for the surgical treatment. The question is when to consider a surgical treatment. When will you call it a day that I am not going for further aspirations? A failed medical management is defined if you are given sufficient things for an hour, and it includes an aspiration as well as an injection of sympathomimetic agent. There is no response. What is a no response? The acidosis is persisting. If you're repeating the ABG, the acidosis is persisting. There is anoxia, rigidity, lack of arterial flow by an ultrasound, and there is increased cavernosal pressure. There is no, it can be called as a non-response, and you can go for a surgical treatment. And your patient is a high cardiovascular risk patient. You don't want to inject the sympathomimetics, or you don't get a consent, then you can consider a surgical treatment directly. Or in some cases where patient is having a very uncontrolled hypertension, or mono amino oxide inhibitor drugs, who is on such drugs, you may have to directly go for surgical management. When you consider surgical management, our main aim will be, one is pain relief, definitely. Even for a long duration priapism, our main aim will be a pain relief. But we have to minimize complications, like the erection has to be preserved and decrease the chance of corporal fibrosis. So whatever you intervene, you should get a rapid result with the least invasive method. And you have to minimize the complications secondary to the procedure, because already there is some corporal fibrosis meant to be in such patients if it is sufficiently delayed. So with your intervention, you should minimize complications so that patient will have a better chance of erection. So what are the ways we can achieve this? One is creation of a shunt between the corpora cavernosa and corpora spongosa. You create a passage between these two, or corpora cavernosa and the veins. Glans is also part of the spongosa, so I am not separately mentioning it. Corpora cavernosa to corpora spongosa, or corpora cavernosa to the veins, saphenous vein or the dorsal vein, the penis you can use. Second principle is we have to restore the arterial flow in the corpora cavernosa, and that is our ultimate aim. You have to restore the arterial flow. You don't want a cavernosa filled with the thrombus. You want it to be completely free out of the thrombus, so that and you need a free flow so that the venous drainage is also fine. And third thing, we want the shunt to be patent. Till when? Till the venous drainage is normalized. After that, we don't want the shunt, because the venous drainage will be taking care of it. So we want the shunt to be patent till the venous drainage is normalized. This needs a wider area of the shunt to prevent it from getting closed due to post-ischemic hyperemia. Once your shunt starts working, there will be some edema, and your shunt gets blocked. So you have to keep a widely patent shunt that will help you to remain patent till the venous drainage is normalized. Fourth one, a spontaneous, we want the shunt to close spontaneously. When it could be either by a clot, it could be by normal tissue formation. We want it to be closed after the recovery of the venous drainage mechanism. Otherwise, there will be a persistence of the erectile dysfunction. So a patient will be becoming erectile dysfunction because of your treatment, because you don't have a erectile mechanism happening. You have created a shunt. This usually occurs as normal arterial flow cannot keep the fistula open. A normal arterial flow happening, it cannot keep the fistula and it will get closed. But we want this to be done spontaneously. If it is not happening, we may have to go and close the shunt after some time. This is actually what we are doing, the corpora cavernosa to the spongiosa. Both corpora cavernosa to the spongiosa, we are making a shunt. Now, one more point we have to focus not mentioned in the guidelines, but I read it from Tom of Liu, and those who want to practice it also practice it, because there is some sense in this recommendation from him. What we need is a shunt to be patent till the venous drainage is normalized. And what we are afraid of it is getting thrombosed later. So why don't we start a perioperative anticoagulation? Just before you do the shunt, you can start the anticoagulation. You do the shunt, and postoperatively also you give anticoagulants. But it is not mentioned in that in some of the textbooks. So you may use it in your practice if you are finding it safe. And if you look at if you grossly classify the types of surgical approaches, you have the distal shunts and the proximal shunts. The distal shunts, there are two types. One is a percutaneous shunt and one is an open shunt. Proximally, you have no percutaneous thing. You have the corpora cavernosa to the corpora spongiosum or corpora cavernosa to the vein, like the saphenous or the dorsal vein. What are the type surgical approaches, named approaches? Ebbie-Hodge, the percutaneous one is the Ebbie-Hodge, Winter, T-shunt with corporal dilatation, and open distal, which is Algorab and the corporal snake. If you look at the open proximal shunts, you have the Quackles and the Sacker, which is the corpora cavernosa to the corpora spongiosa, and corpora cavernosa to saphenous vein is the Greyhack, and corpora cavernosa to the dorsal vein is the Barnes. I'll be detailing each one, and the relevant points will be discussed. One is a Winter shunt, which is a very simple shunt where you are just poking in a needle. This is good for early cases. Just like an aspiration, what you are trying to make is a small connection between the corpora spongiosa and the corpora cavernosa. You put a needle through the glands into the corpora cavernosa and you have that shunt. This will work only in cases where there is not much thrombosis and it's not much delayed. Otherwise, it will get closed very fast and it will not drain also. Second one is the Ebbie-Hodge, which is a little more invasive, where you are using a 11 number blade instead of your needle. The process is same. You poke the 11 blade through the glands into the corpora cavernosa, make a sufficiently wide incision there, enabling the blood to come out through that shunt. This also is better in an earlier cases. It may not, it may get closed faster. That is the biggest problem. And if it is highly thrombotic, it may not work at all. T-shunt is the most favored shunt for many surgeons now. Here what they are doing is not the 11 blade knife, they are using the 10 blade, which is slightly wider. They make an incision through the glands into the corpora cavernosa, parallel away from the meatus, so that your urethra is not damaged. Once you reach the corpora cavernosa, you rotate it 90 degrees so that it and take it out. So it becomes a T. After that, this is a T-shunt itself. You can, in earlier cases, you can stop the procedure with this. If you are getting a sufficient detumescence, you can stop it. If you want to do it in the other side also, you can do it. You can do it bilaterally. And if you're finding it comfortable, you stop it. But if there is a lot of thrombosis, lot of clots inside, your incision may not work. In such cases, a 22 French dilator is introduced. Try to keep it as lateral as possible because you don't want to injure the spongiosa or the urethra. You keep it more lateral and pass it through the corpora cavernosa. if you want to repeat it on the other side, you pass it through that. You can utilize the other corpora also. You can decompress the other corpora also. So once you dilate the corpora cavernosa, you will have the thrombus coming out. You have all the blood coming out. So this is, even though we say that this is a distal shunt, this is actually a proximal shunt also, because we are going up to the crura, up to the proximal part and doing the dilatation. So even though we are making the opening in the distal part, it is a proximal shunt also. That is the beauty of it. And here you have to close the wound superficially, because you don't want to obliterate the fistula. But you have to do a continuous suture to avoid the bleeding, because glans is a vascular area. And you should never give a tight dressing, because you want the fistula to drain. You don't want to obliterate. We want the fistula to drain. And after some time, definitely some edema is going to come back and it may obliterate the shunt. This is a picture of T-shunt. You are poking it and taking it out straight. This will be the final incision like. And this is a ultrasound picture of a T-shunt being done. You can go like this. This is a picture of dilated tract. Now comes the Algorab shunt. Here what we do is you really make an opening in the glands, and a 5 to 5 mm opening is made in the tunica albuginea, so that there is a sufficient shunt between the corpora cavernosa and the spongiosa. So a 5 into 5 mm opening is made so that the shunt remains patent. Unlike in winters where you put in a needle or in a 11 blade knife, the advantage here is we are removing a certain amount of tissue which will keep the thing wide and patent. The other one is the Burnett's technique or the corporal snake technique. This is almost similar to the T-shunt, but it is a continuation of the Algorab's technique. Here you have a 5 into 5 mm opening in the corpora cavernosa through the corpora spongiosa. There is a shunt, and that Hagar dilator is introduced just like in the T-shunt, and the blood is squeezed out, and it is also functionally a distal and proximal shunt, and there are many literature supporting the efficiency of corporal snake technique. The complication will be a urethral-cutaneous fistula, a pineal necrosis, and wound necrosis. Distal shunts, the complications are erectile dysfunction, as in any other shunt or any other treatment for priapism or priapism itself. Glandular hypoesthesia, change in penile sensation, poor osmosis, and need for repeated procedures. Now we are coming to the proximal shunt. The quackles between the corpora cavernosa and corpora spongiosa. There is a little confusion of the names. In some text it is given in a different name, but I prefer, maybe in exams it is more important, but the principle is very important. You are making a connection between the corpora cavernosa and the corpora spongiosa in a penoscrotal area. The problem with this area is you have a very thin corpora there, and there is some chance of some fistulas happening. That is why Sacker has come out with the perineal approach, but in some books it is written the other one is the perineal approach. But the Sacker's original article says that he is preferring a perineal approach, and he is putting a bilateral staggered incision, 1 centimeter apart. It can be done bilaterally. It is done at 2 areas because to avoid a stricture, and you know that bulbar urethra you have a thick corpora spongiosa, so you have a sufficient space for it, the corpora cavernosa to drain, and you are keeping away from the urethra. That is why the perineal approach is its importance. And the clot and blood should be milked out of the ischial part of the corpora cavernosa. That is also possible. And the advantage of the perineal approach is easy access and visibility, thick spongiosa with the urethra away, and filtering of the blood to avoid embolism, like if you are using a straight, you are anastomosing the corpora cavernosa to the vein, there is no filtering happening, and your thrombus can go into the systemic circulation and embolism can happen, and that is reported. And there is clearance at the entry of the cavernous arteries itself, because it's very more proximal. That is these are the advantages of the Sacker's procedure. Then in some cases you may have to do a shunt reversal, because this may remain patent for a long time even after the reversal of the priapism. Now comes the gray hack. Here the saphenous vein below is joining with the femoral vein is used to have an end-side anastomosis. A separate dissection is needed. The chance of embolism, as I mentioned earlier, and chance of obstruction, because it has a curved track, so there may be a chance of obstruction. This is a gray hack's procedure. And the Barry shunt, you don't have a tortuous track, or you don't have a two separate incisions. You can do it. A deep dorsal vein to the corpora cavernosa. A wedge of T has to be removed, otherwise it may not remain patent. The chance of blockage and the persistence of shunt, both are problems. In some cases, it may get blocked faster. Some cases, it may remain patent even after the priapism is settling. Now, another issue is a delayed priapism when it comes to you. We have to really discuss about the possibility of an early prosthesis implantation in such patients. Why? Because if you have a very late presenting ischemic priapism, or priapism require refractory to treatment, there will be corporal fibrosis and loss of penile length. If you are doing it late, after some time, the chance of corporal fibrosis is very high. Thick fibrosis you can have injuries and high rates of reoperation. And inflatable prosthesis will not be feasible because of the thick fibrosis. In such patients, an early prosthesis implantation can be suggested, because it can preserve, you can preserve the length. It is easy to implant. Lens fibrosis, definitely the complication of revision will be more compared to a normal prosthesis implantation, but it is always better than a late prosthesis implantation in a post-priapism patient. When to consider it? The EAU guidelines tell that it has to consider it before more than 36 hours, and in some others suggest more than 72 hours. So that depends on your discussion with the patient. Now we have to have an algorithm how to manage it, because we know what are the steps, what are the armamentarium we have, and how to stratify it. Initially, the history, physical examination, blood gases, duplex ultrasound, you make a diagnosis. Finally, you made a diagnosis that is an ischemic priapism. In that setting, if it is less than 24 hours, you can very well go with evacuation of whole blood, your phenylephrine, and other things, because you are not going to get it cleared within 24 hours. If it is 1 to 2 shunt day, 1 to 2 days, you may need a shunt. If we prefer a T-shunt, you can do a T-shunt. If you want to anticoagulate, you anticoagulate. If you want a corporal stake maneuver, you can go with that. Depending on the case, you can plan a shunt in 1 to 2 days. If it is more than 2 days or 2 to 5 days, your shunt may work or may not work, or early processes has to be considered. That depends on how you discuss with the patient. If you have a patient with the priapism more than 5 days, the first thing you have to note is you have to check whether the history is reliable. Some intoxicated patient or psychiatric patient may tell that I have it for more than 5 days. But if you have an unreliable history, it is always better to go through the routine pattern of aspiration, injection of sympathomimetic agents, shunts, and other things. And in some patients, even if they tell that it is 5 days, it may not be 5 days, because it may be an incomplete priapism. In between there, you have an incomplete priapism and some cavernous blood flow may be there. So it is always better to have a trial of aspiration and a phenylephrine injection, but after discussion with the patient and documenting it. If suppose you are putting a needle and a sudden gush of blood, reducing the priapism to 50%, this is a positive sign. But if it is a very poor trickle of blood without much change in the rigidity, it shows a poor prognosis. These are situations where we are managing a patient with the priapism of questionable more than 5 days. The otherwise, if it is a very documented case, or we are dead sure that it is more than 5 days, that we may not treat at all with any shunt, because we need only treatment for pain. Sometimes T-shunts will also help in alleviating the pain in such patients. A process implantation can also be discussed. Now, just to ease your mind, this is the Haisintang Park. I haven't visited this park. It is called the Penis Park. It is in South Korea. It is actually a part of a legend in that area called Obhavi. That is a lady was there who got drowned in the sea, and her man could not save her. After that, what the natives observed is that they are not able to catch fish in that area. So what they did, they kept away from that place. But one day, one man urinated in that sea, and suddenly they had they were able to catch fish. These are all legends. I don't know whether it is true or not. It's just for an interest sake. After that, they thought that it is a virgin girl who was pleased after seeing the penis, and they started offering pennies in that area. Different types of pennies they made, and now there are a lot of statues in the Penis Park. So I was not coming to that. I was just mentioning about partial priapism. It's just a distractor. This actually comes not like a priapism. It comes as a perineal pain and a swelling in the perineal region. It can come after a bicycle riding trauma, sexual intercourse, drugs, and some hematologic disorders. The importance of knowing this entity is, if you are taking a CT or an MRI and seeing that there is a partial thrombosis of the penis, you can treat it conservatively and it will get relieved. Only one of the crura will be involved in partial priapism. So now we'll move on to the high flow priapism after completing the low flow priapism, which was the more important one. In high flow priapism, we all know that the spontaneous resolution is happening in 62% of the patients. Even an ultrasound compression may be helpful in obliterating the fistula. Suppose some patient is telling that I can't go walk around with a fistula like this, with a tumors and penis like this, you can go for an angiography and embolization. The success rate is very good, and recurrence rate is only 30%. But the problem is post-embolization erectile dysfunction can come in around 14 to 25% of the patients. And what we usually do in such patients is we prefer an absorbable material for embolization so that it is easily reversible. In priapism management, what we need is, initially we need a shunt or a block in flow, and later we need it to be corrected, because we want the erection back. We don't want the erection for a particular period of time, and then we want the erection back. So we use absorbable materials. Other things we can use is a polyvinyl alcohol, cyanacrylate, or gel foam. Bilateral procedures will be more prone for a erectile dysfunction. When will you go for a surgical management in a high flow priapism? The indications are very low, unless the patient is preferring for a surgical management or a failed angiographic embolization, or he is a poor candidate because of the renal problems or contrast problems or contrast allergy, or technology is not accessible in your place. But the problem with acute intervention is, finally you may end up in ligating the cavernous artery, because you don't know what is what, and finally everything will be oozing and you have to ligate the cavernous artery. But if you are going for a transcorporal approach, after some time of the fistula formation, there will be a pseudo capsule. You can nicely ligate it, and the patient can be relieved. Now we will go to the management of stuttering priapism. It has two types of management, mainly the acute management, where you can use the oral drugs, not unlike in low flow priapism, and intracavernosous injection of the alpha adrenergic drugs you can use directly without aspiration. Then the main thing will be the prevention part. where you can use the hormonal treatments, baclofen, PDE5 inhibitors. The hormonal, there are different types of hormonal treatments used. The basic logic is to reduce the testosterone to hypogonadal level or to block the androgen receptors. You know the how to reduce the testosterone to the hypogonadal level. You can try all these things, including your ketoconazole 200 milligram TID plus prednisolone night in the 3 months, followed by ketoconazole 200 milligram OD. Your finasteride, dutasteride, everything is mentioned, and you can try using all of them. Second is the baclofen. I haven't used it, so I'm not aware of its use. It is mentioned like it inhibits erection due to stimulation of the GABA B receptors, and this also is mentioned as a part of the treatment. Phenylephrine, it's helpful in averting an acute episode. If you are doing a self-administered injection, 200 milligram intravenously, acute episode can be managed, and it can be the patient itself can be asked to do it if it is a very frequent stuttering priapism, which cannot be prevented by your conservative measures. PDE5 inhibitors is a treatment for stuttering priapism. Unlike our belief that PDE5 inhibitors are for causing erection, there are some recent understanding of the pathophysiology of erection, stuttering priapism, and the sickle cell disease, which tells that PDE5 inhibitors is very useful in preventing the stuttering priapism. Why they think about this possibility, or why they are getting a good result, is because the PDE5 expression is modifiable. It is affected by the CG, the cyclic GMP. In priapism, what happens is the PDE5 is down-regulated. It is very less. So if you are using PDE5 inhibitors continuously, there is increase in cyclic GMP and cause increased expression of the PDE5. So once the PDE5 expression is increased, the stuttering priapism comes down. It's found to be very effective. Sildenafil 25 to 550 milligram, morning hours with the flaccid penis. It has to be given with the morning hours after you have a flaccid penis, and avoid sexual stimulus for a few hours. Tadalafil 5 to 10 milligram can also be given on alternate days. Its efficacy comes after a week. There are some oral agents being described, but it is not after 4 hours. It is used for prolonged erections like terbutaline, 30 to 42%, phenylpropanolamine, 28%, and pseudoephedrine also can be used. Then other measures we know, some people try an ejaculation exercise, cold compress, cold bath. These are the behavioral modifications which can, or household remedies which can be used in a prolonged erection. Thank you for your patient hearing.
Thank you. Vinod, you are feeling okay? You want to take rest?
No, anything is fine.
There are a few questions in the chat box. Are you okay to take it now? Okay.
Yeah, no problem.
Okay. I'll just take one by one. The first question was from Dr. Rahman. Is there any role of embolization in the management of ischemic priapism?
No role. Absolutely, because there is no question of embolization in ischemic priapism.
I think you have nicely covered the role of both the absorbable and the non-absorbable agents for high flow. There's a second question from Aditya. Probably you have covered in your class very well, but still we'd like you to answer to him. What is the golden hour period in the successful management of priapism?
At the earliest. There is nothing like a golden hour. Even though we say that we have to define priapism after the 4 hours, you need not wait for the 4 hours. If you are seeing a patient very early, you can, before that 4 hours, you can give all oral drugs. When you are getting a call, you can ask them to even give a intracavernosal injection of phenylephrine if you have a good assistant with you. So there is nothing like a waiting period. You can try early. Why we wait till 4 hours is there is a chance of spontaneous resolution. So you give the chance for that. But if you are skeptical about that, you can start early. The earlier you treat, the better will be the result, because our ultimate aim is avoidance of acidosis, which is going to start the cascade of pathological events, you stop the acidotic part. You intervene early, you prevent hypoxia, hypercarbia. So that will be our strategy in that.
I'll take another question. Dr. Naresh wants to know from you, and you have covered in your class also, what's the difference between prolonged erection and Priapism?
That I have already mentioned. It is a time period of 4 hours. Why we have kept it 4 hours also I have mentioned. One, you don't want to, if you are doing some, we need a standardization to do our studies and other things. 4 hours is a time period when you don't have a problem with the hypoxia also, because it takes around 6 to 8 hours to have a hypoxia. So once you have a prolonged erection, you have to treat it if possible. Otherwise also it is fine.
Another question from Dr. Stephen Stello. Treatment of Priapism because of pelvic venous thrombosis, other than the normal treatment of thrombosis, any other supplement Meyers or any other supplement treatment, adjuvant treatment?
No, Priapism, for that matter, if you have an acute episode, our main aim is managing an acute episode where you want to avoid hypoxia and acidosis. If you have any other cause, whatever may be the etiological cause, I have mentioned in the previous slide also, whatever may be the etiology, if you have an acute setting, you treat it acute. You treat it just like any other low flow Priapism.
There was, I think this was the first question which Dr. Anand Kamant put it. What is the incidence of permanent impotence after the Priapism induced by intracavernous injections?
That depends on your intervention, because see, when you are putting IC ward patient on intracavernous injection itself have a erectile problem. That is why he is taking it. So that patient will have a corporal fibrosis to some extent. That depends on how fast you are intervening it. If you are intervening it late, you can have a permanent impotence. If you are intervening early, you can relieve the patient. But your impotence may not be due to your Priapism. Maybe a underlying pathology he said.
Dr. Vinod, Dr. Venugopal wants to make one comment. I'll just pass on the over to you, sir. Want to ask something? Yeah, yes, sir. We can hear you.
I would like, excellent talk, Vinod. Let me congratulate you for that.
Thank you, sir.
But what I would like to know for the students' sake is that which of the distal shunts that you will prefer as a first choice? Are you going to do a proximal shunt straight away? I think you have been talking more about distal shunts. Which of the distal shunts would you prefer?
Sir, I will go for the T shunt, and one side. If it is not relieving, I will go for the dilatation on that same side. Even after that it is not completely clearing, then only I will go for the other side.
How do you decide the time? How do you know that this is not working?
I have mentioned in my class also, sir.
I heard you telling, but I'd like you to repeat it because
okay, sir.
I'm confused. So
yes,
students
sir. Okay, sir. So once you put a dilatation, you squeeze, the thrombotic blood has to come out, and when the bright red starts to come out and no more thrombus is coming out, that means you are done with it. The only problem is once you suture it and after some time you see that the penis is getting engorged, you are confused whether your shunt has not worked, you have a recurrent Priapism. That is your confusion. In such cases, you have to see the ultrasound. If you are seeing that there is sufficient blood flow into the corpora, then you can forget about it. If you are seeing that your corporal blood flow is not there, then you have to do the shunt on the opposite side.
Can I say that it's almost in reciprocation with torsion testis?
Sir, I didn't get it.
Torsion testis also, you do the same thing.
Yes, sir.
whether blood flow is coming or not. Are you doing
Yes,
the same thing as far as priapism also is concerned?
There we are looking for the redness by the color. Here also you are seeing the redness of the blood. That's only difference, sir.
Arun, I think you should ask for this quiz to start. We can have the
Okay.
discussion continuing.
Yeah, the quiz link is open. We'll continue with the question, sir.
Yeah, you can continue with the questions.
Vinod,
Please
just now
can
I've got
log
two
on
more
to that
questions.
link and do the quiz. It's for 10 minutes.
Link is already there in the group as well as the chat section. If you have any problem, please just message through central office or Navneet call. Vinod, there's a question from Karandeep that we had a case of carcinoma urinary bladder with penile metastasis and priapism. Is there any difference in management? So this is a
In
secondary
metastasis, we are not bothered. We are not. We may not be able to give a proper erection after to this patient because the whole of the corpora may be filled with mets. So before starting your procedure, it's better you get an MRI imaging or if not possible, at least by an ultrasound imaging, see the amount of metastasis inside the corpora. So our main aim in such patients is not an erection, not avoiding the corporal fibrosis, because anyway the metastasis is going to come and it is going to spread. Our aim will be palliation of the pain. So in such patients, we can do what if you want to do a dilatation of the corpora, and if it is relieving the pain, it is okay. But it is not otherwise going to change the management. Our approach will be mostly of a palliative intent than a therapeutic intent if it is a widespread metastasis.
What is the role of biopsy, cavernosal biopsy, in deciding whether this patient would require a penile prosthesis or not?
Biopsy is basically for a documentation purpose. Otherwise, it is not going to make any difference.
Is there anything which will indicate to us that you have to put a penile implant straight away and wait for it? Is there anything which can tell you that you go ahead and do a penile implant for this patient?
No, with the biopsy alone, we cannot say. Before doing a biopsy, or you can have the corporal biopsy for a documentation purpose. That's all.
So is there a role of MRI which can give us an indication that this patient would require?
That may help. That may help, because biopsy we can take only from one or two areas. We don't know what is happening in the other areas. To assess the corporal smooth muscles, to assess the corporal fibrosis, MRI is a good option. So if you want to have a better discussion with the patient regarding an early prosthesis implantation, you can definitely go for a MRI and discuss with the patient the pros and cons of that.
Vinod, one more question from Dr. Sharma. This is not priapism, but something lesser than that. How to manage penile erections and counter during the endourology procedures? It's intra-op. Say you're doing TURP, is something other than priapism.
It's a prolonged erection. That's all. So first thing is that is actually something different. But still, when what we usually do is when you are preparing the patient, don't too much play with the penis. Even betadine sprays can be used, because if you are putting too much betadine by your sponge holder, it can itself create an erection. Secondly, if you are having a anesthesia, you can ask them to deepen the anesthesia, because spinal anesthesia may create a erect penis to some extent. And in practically, what we are seeing is when you are, if you are doing a TURP, if you are starting the proceeding, after some time this will go off by itself.
Yeah. Agreed. I think this is nothing more in chat section. Dr. Keshav, we have time?
Yeah, we have time.
I'll just share one small poem which Dr. Lakshman has sent to me on WhatsApp. I just made some cosmetic changes. I thought I'll just share with you. Can you see it, sir?
No, we are not able to see.
Not able to see. Okay. I just share it. Can you see it?
Yes. Yeah, full
Okay.
screen.
So yeah, I made full screen. So I think this summarizes what Dr. Vinod KB has put in his a very nice lecture. It says like this: when the tip is soft and the rest is tough, when the thing is long and the pain is rough, when the lust is least and one say enough is enough, the flow may be slow or high, inside full with deoxygenated. Man, it's Priapism and not the time to bluff. Indeed, it's a time to restore the circulation trough. Let oxygen-starved smooth muscle breathe up to the penile cuff. Pill, shots, and lot for player, irking Priapus, my dear muff. So this is a poem written by Dr. Lakshman with some cosmetic changes when I was just listening to your presentation. Over to you, Dr. Keshav.
Yeah. Thank you, Dr. Arun. Thanks, Vinod, for an excellent lecture. We have got very positive feedbacks on our chat box also. None other than Sanjay Kulkarni telling that it was an excellent lecture. And it was good. It was none of the people who had logged in left in between your lecture. All of them were glued to your presentation. It was informative. It was very good lecture. Thank you very much for your
Dr.
effort
Keshav,
to do it.
Dr. Keshav, 1 minute. Because Dr. Sanjay is here, let me just corollary to the last question. Can I put a question to Dr. Sanjay? He's here only.
Yeah, you can.
Yeah, this is regarding that not intraoperative, but the post-operative erections, the management, especially with the patients, the children and the adult being operated for hypospadias and the urethroplasty. Your opinion on that, sir?
No. We don't treat the patient to prevent post-operative erections. But intraoperatively, as Vinod was saying, what happens, we do urethroplasty or most of the urological procedure under spinal anesthesia. And then before the anesthetist gives spinal, the patient is giving position. And before the anesthesia sets in, which may take few minutes, 5 minutes, the nurse starts painting the patient, and that may actually cause erection. And then which is very common during urethroplasty. And then we start phenylephrine intracavernolar injection. There is a chart written how to dilute and everything in the theater wall itself. And we have no hesitation in treating patients, because if I want to do a bulbar mobilization, it becomes very difficult. Surgery becomes difficult if the patient has erection. You can't do a TURP, so you have to treat and make the patient flaccid.
I think, Vinod, before I hand over to Dr. Keshav and Dr. Ajit for the closing remarks, let me see the messages on my WhatsApp. Also, an excellent presentation. I think 3-4 slides which you have put, one which is regarding the history and the clinical evaluation, keeping in view the duration, that is an excellent. The second slide also is, I think, the master slide where you have put the differentiating points between the different type of Priapism from the history, the color Doppler finding, and the blood gas analysis. That was the best. And one slide which is showing the algorithm with the time management of a few hours, and after that, that was I think the key, which I think summarizes the whole presentation, and excellent. Over to you, Dr. Keshav, and then over to Dr. Rajiv. So
yeah, thank you, Arun. I must thank Lupin for the academic grant which they are given for the conduct of this. Thank you, Lupin Formica, for this. And over to Dr. Rajiv Sood for his closing remarks.
Thank you, Keshav. Thank you. A big thank you to Dr. Vinod KV for his excellent lecture and covering extensively each and every aspect. As in the beginning, I have told that this is the COVID era. Stay safe. It is very bad times are going on, and I have shared with you, as today we are talking about priapism. Initial reports of priapism after the thrombogenicity of COVID has been already reported, and that is ischemic priapism has been reported, and those reports are coming, and we will be wiser in the time to come. Anyway, as far as the residents are concerned, it was the feast for them, and it was so many residents have attended today, and this is serving this distant learning is serving the right purpose. All the faculty, all the residents are extremely happy with these lectures, and this lecture Dr. Vinod had made really very, very interesting, very, very interactive for the faculty also, who are that stalwarts who are present, Dr. Vinu Gopal, Dr. Sanjay, Dr. Lakshman Prabhu, and Dr. Keshav, and Dr. Vinod, and Arun Chawla, and all. So this was wonderful evening. This was wonderful program, and we are sure that such programs will make our day every Tuesday, and in the evening at 7, and we will be doing these programs full justice as Dr. Vinod has done, and wait for the next program with another outstanding faculty who is going to be teaching our residents and interacted with them. Good night for today evening. Thank you very much for being with us, and all the residents are to be congratulated for participating throughout. Continuously they were glued to the screen. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, Dr. Sanjay. Thank you,
Thank
Dr.
you, sir.
Lakshman. Thank you, Vinod.
Thank you,
Dr.
Sanjay, sir.
Keshav. Bye.
Thank you.
Thank you. Bye, sir. Good night, sir. Good night.